Welcome. I am Riley, the gut pharmacist. I specialize in gastrointestinal disorders and chronic illness. I'm a traditional naturopath. And today I'm going to talk about the two types of reflux, GERD and LPR, the similarities and differences between the two, also root causes and solutions. Okay, so first, I want to talk about the similarities and the differences. So, they are both types of reflux. There can both be throat clearing, coughing, throat irritation like esophagitis involved, nervous system issues, because pretty much all digestive conditions have a root in nervous system dysfunction, considering that intimate brain connection, which I do have some videos on if you'd like to check that out. They can both have a bad taste in the mouth and they can both have low hydrochloric acid, which is stomach acid. Contrary to popular belief, most people with reflux are actually low stomach acid secretors. Reflux is not a high acid issue. It's just that acid is in the wrong place. It can be the smallest amount of stomach acid, it doesn't matter. But if it's in the wrong place, it will cause issues. We are treating reflux with acid suppressing medications. While that is helpful and indicated for serious issues like Barrett's esophagus, esophagitis, gastritis, ulcers, they are indicated for those situations, but they are meant to be used short term. These medications suppress acid when acid is the byproduct of the dysfunction going on. So I wanted to make that clear, and we'll talk about solutions shortly. But those are both types of reflux. They have the similarities. Now let's talk about the differences. So, gastroesophageal reflux disease, which is GERD, is mostly known as the chronic heartburn, and there's a clear burning sensation. With the other type of reflux, LPR, which is laryngopharyngeal reflux, the burning sensation is not always there. So it's a chronic non acid reflux. With GERD, there's often lower esophageal sphincter dysfunction, which is that opening from the throat to the stomach. That sphincter is pH and pressure dependent, as well as some motor control from the nervous system. But most people with reflux have dysfunction with the LES. With LPR, there actually is upper esophageal sphincter dysfunction, which is that opening from the like the swallowing area. So the upper esophageal sphincter, that opening right by where the respiratory tract and the esophagus kind of connect and separate. So with GERD, there's more of LES. With LPR, there's upper esophageal dysfunction. But with both, there is sphincter dysfunction in general. So those openings that prevent flow of food and stomach contents, those can be dysfunctional. With GERD, there's often chest pain, that clear burning, and heartburn. Sometimes people feel like they're having a heart attack. There's a lot of chest symptoms, also nausea and hiatal hernia. With hiatal hernia, a lot of people get really caught up with this. Hiatal hernia does contribute to reflux, but it's not the sole contributor. There has to be other factors in place that also contribute to reflux. There's a lot of people with hiatal hernia that don't have reflux. So there's a correlation, but not a direct connection or cause. Okay, so that was GERD, more of the burning heartburn, chronic heartburn. With LPR, this is the silent reflux. So it's not always apparent that people are refluxing, but they can definitely feel that something isn't right. So this is the silent reflux, chronic non acid reflux. Usually there's some upper swallowing dysfunction, lots of mucus, feel like they're choking on mucus all the time. There can be shortness of breath, air hunger, sometimes stomach contents like pepsin, which is a component of stomach acid. It's an enzyme that helps break down proteins. So, stomach acid does go with pepsin, but they're two different parts of the stomach juices. With LPR, there's usually dysfunction with pepsin. Okay, so pepsin can aspirate up into the throat and even get into the ears and the sinuses. So often people with this LPR silent reflux, they go and see ear, nose, and throat specialists, which isn't usually the case with GERD. But with LPR, we can also have the air hunger, shortness of breath, as I mentioned, because that pepsin can aspirate into the respiratory tract. Also, hoarseness, losing the voice or throat, a lot of throat issues and sinus issues as well, postnasal drip, things like that. With LPR, there's often an extra immune component. So, underlying triggers like pathogens, even mold, those can also trigger LPR. So, GERD is more of the burning, heartburn. LPR is more issues with pepsin, ears, nose, and throat, a lot of mucus issues. Hopefully that makes sense there. Okay, so reflux medications, I want to talk about this for a moment because this is the primary treatment for both types of reflux. So the medications are helpful. Again, sometimes they are indicated in certain cases to prevent damage to the upper esophageal tract, prevent Barrett's esophagus, even ulcers and gastritis. However, the medications, they don't fix reflux. The reflux still happens, you just don't feel it. There are many risks of these medications. So, omeprazole, pantoprazole, medications like that. So, the risks I've listed, and there are many, but we have nutrient deficiencies, and I listed a study there. So it was proton pump inhibitors and risk of vitamin and mineral deficiency, evidence and clinical implications. So the citation is there. But many studies show certain nutrient deficiencies, especially like calcium. So there's a connection with osteoporosis, hair loss due to not absorbing proteins and certain nutrients. So these do have a risk of nutrient deficiencies. Can you supplement these nutrients? Yes, but overall, you're taking a medication that likely isn't fixing the underlying issues unless you have a specific condition that you are taking these medications for. But again, they don't fix reflux. Also, SIBO and IMO, those are small intestine bacterial overgrowth and intestinal methanogen overgrowth. Proton pump inhibitor use is associated with a risk of small intestine bacterial overgrowth. This is a meta-analysis. You'll find some studies that say there's not a connection, but a meta-analysis is the most elite type of research paper. So just keep that in mind. Also, because stomach acid prevents pathogens from coming through the stomach and the GI tract from the food or the drinks. Nothing we eat or drink is sterile. So, stomach acid has this sterilizing component. So, without it, we are more at risk of specific microbes and infections. And C. difficile is one of those. SIBO and IMO technically aren't infections, but those are types of microbial overgrowth. So, again, we're not sterilizing as we should be without stomach acid. Hair loss, as I mentioned, osteoporosis due to calcium deficiency, even vitamin D, H. pylori infection, another type of microbe, which is actually linked to gastritis and ulcers and sometimes even reflux. We are more at risk for a microbe that increases the risk of reflux when we're taking a reflux medication. So you can see how that's kind of contradictive there. Also, parasites and other pathogens, again, because of that lack of sterilizing effect. So the medications do help, but they actually don't fix reflux. The reflux still happens. You just don't feel it because there's no stomach acid anymore. So let's talk about what actually happens in reflux. With the most common root causes that I see in practice, there's a lot of things. There's never one thing. Again, it's a multifaceted condition that develops with a variety of factors. It's never just the hiatal hernia or just the sphincter dysfunction, all these other factors come into play. So, sphincter dysfunction is a big one, hypochlorhydria, which is low stomach acid, small intestine bacterial overgrowth, and intestinal methanogen overgrowth. Because of those conditions, and I do have a video on that in case you want to learn more, SIBO and IMO are huge contributors to IBS and also reflux. So, I have a video if you want to check that out. But because of the increased pressure from the bloating and the gas, there is more of a risk of reflux. Dysbiosis, because there can also be gas and fermentation in the colon that can create some pressure, and also certain microbes are linked to reflux in general. Hiatal hernia, that's one factor. Obesity, of course, because of the extra abdominal pressure, likely poor eating and lifestyle habits, but you can also be thin with a big belly with lots of pressure on the stomach. H. pylori, talked about that. Also, mold. That's a very overlooked one. That's not something that is considered in allopathic medicine, usually functional and naturopathic medicine. But mold, I see it in so many of my LPR clients. That is a big one, to be honest, and it's very overlooked. So, with reflux, what actually happens is that we have multiple things going on at once. So, there's an increase in pressure in the stomach, there's decreased pressure at at the top of the sphincter. So if we look at this diagram, there's pressure imbalances in general. So increased pressure underneath and decreased pressure above. So as you can imagine, because of that mechanism there, we're going to have things coming up. So reflux comes up. And increased pressure can come from many things: obesity, pregnancy, delayed gastric emptying. Hint, hint, usually that's a low stomach acid issue. But as I mentioned, also SIBO, IMO, dysbiosis, those can also increase pressure for things to come up. There also has to be a defective barrier. So, if there is already some esophageal erosion, of course, if you're refluxing, you're going to have more of a risk for esophagitis and then also gastritis too. So, our barriers are very important for many things. There also has to be some motility dysfunction. That's also an issue with SIBO and IMO. That things start building up in the small intestine due to motility issues, but there can also be esophageal motility issues, which can contribute to reflux. Of course, if there's lack of motility in the large bowel causing constipation, that can increase pressure. So there's many things that are involved here. But this is the overall way that reflux can actually occur. And again, I've listed the main root causes that I see mixed with, clinical things with my clients, but also based on research. So this diagram, there's the source there at the bottom right. That was in the World Journal of Surgery. So a very elite source for this. Okay, next let's talk about root cause solutions to reflux. It's not about what can I take. That mindset doesn't work. What can I take just quiets the symptoms. It doesn't actually fix the problem. So stop asking what can I take? Let's start asking what is the problem? What is the cause? How can I fix this? Okay. But individuality always needs to be considered. Again, some people who or most people with reflux have low stomach acid, but most people or some people may not actually be ready to incorporate that acid support. So we have to always consider the individual and we have to consider those individual root causes. I've listed a ton, but they're going to be slightly different for each individual. So some people may have mold as a contributor, others may have esophageal motility or SIBO as a contributor. So everyone is slightly different. But these basic things to address, I can't get specific today because everyone is so different. But basically, I start with environment, making sure that we're not living in a traumatic situation, abusive relationship, something like that. Also, not living in mold or carbon monoxide. Obviously, that's not going to promote health and vitality. So, number one, the environment has to be healthy and safe. Then we can start to regulate the nervous system. So, with basically every gut disorder, because of that gut brain connection, there is some nervous system dysfunction. So, that's a huge thing that I help to regulate. Also, digestion starts in the brain. So, if we're eating in a stress state, we're in fight or flight mode, we're not going to be secreting our digestive secretions like stomach acid. Things won't start moving. We're not going to have that motility. So, we have to balance the nervous system as one of the first things. Nutrition, of course, that's a basic. Nutrition is huge with reflux. Got to make sure that we're eating things that sit well with us and don't contribute anymore. Mealtime habits, so specifically chewing 20 to 30 times, that's a huge one. Most reflux people actually have poor eating habits that they overlook. So, eating too fast, not chewing properly, drinking too much while they eat, that dilutes our digestive secretions and also increases pressure. So, we're more at risk for reflux if we're just drinking a bunch of water while we're eating and then we're not chewing 20 to 30 times. We want to make sure that food is broken down so our secretions can cover the food particles properly. That way, there's less pressure and less chance of reflux. We want to make sure that we're taking care of our barriers. So, our stomach lining, that mucosa layer, our esophagus, that mucosa layer. We want to make sure those barriers are healthy and protective so that when we do eat, and or support our stomach acid, maybe like taking HCl or apple cider vinegar capsules. I usually recommend capsules, not liquid, by the way. We want to keep acid out of the throat as much as possible. But back to my point, we want to support those barriers so that when maybe we do have an opportunity or are able to take those acids, then our stomach is protected as it should be, because the stomach is supposed to be acidic. We want to make sure that we have adequate stomach acid. It's just that when the barrier in the stomach is compromised, that's when it can become a problem. So the stomach should be protected so that it can handle those acids as it should. And then pH, again, digestive secretions. Usually with reflux, there is more alkaline stomach, and then the esophagus tends to be more acidic when it should be the opposite. So the esophagus should be neutral, maybe slightly alkaline, and the stomach should be acidic. Oftentimes, it's reversed in reflux patients. Motility dysfunction, we kind of talked about that. We have to make sure we're supporting all types of digestive motility, from esophageal motility, also helpful to balance the nervous system for that. The small intestine motility and the large intestine motility have to balance all types of motility so that things start moving, they don't get stuck and increase in pressure over time. And then microbes, we have to balance microbes, making sure that we don't have specific ones that can worsen the reflux, like H. pylori, which actually creates more of an alkaline cloud in the stomach, and that can impair pH, which can then impair pressure over time. So we want to make sure that no microbes are contributing more to reflux. So that was the basic overview of root cause solutions. Again, very generalized. Everyone is different, so I can't be too specific. And there's my sources there. So pretty much everything I've talked about today is evidence-based. And we talked about GERD and LPR, similarities, differences, root causes, and solutions. So I hope that helped. I have plenty of other videos on a variety of digestive conditions and chronic illness, mold, Lyme, and everything in between. So be sure to check those out and support and like my videos. Thank you guys so much.